Hi everyone. We're gonna get started today. So welcome to this month's webinar called Can't Sleep: CBT Tools for Restful Nights for You and Your Patients. And in just a few minutes, I'll introduce you to our awesome presenters, LJ Davis and Kevin Cornelius. I'll just go over a few administrative things first. So most importantly, how you'll get your CE credit today, just make sure that you're here till the end of the webinar. It's a 1-hour webinar and you can access the CE survey in the chat box today. We'll drop it in the chat box for you. Go ahead and click on the link, complete the CE survey right away today, and then you'll receive your CE certificate of completion via email within about a week. Okay, so let me just start out briefly by telling you who we are at Feeling Good Institute, because we bring you these free webinars monthly. So kind of just to give you a little snapshot about what we're all about here at Feeling Good Institute and share with you our mission, which is to make a difference in people's lives through elevating the practice of therapy. So our story started with really one big goal, which was to make therapy better and help people who are going through tough times. And we achieve this by training and certifying therapists in effective therapy techniques. We have a comprehensive kind of 5-level TEAM-CBT certification system that provides a path to mastery in TEAM-CBT. And we have treatment available in over 35 states across the US and Canada, and we offer therapy both online and in person. And we have an intensive one-on-one therapy program where people will fly into town or travel to Feeling Good Institute, or sometimes do it online, where they do many hours of therapy a day, many days a week, in order to get better faster. We also have a lower fee therapy program as well. And this slide is kind of new. I've gotten some feedback from webinars where people say, how come you don't introduce yourself? Because I usually just jump in and introduce our presenters, but I'm always facilitating these. And so I just wanted to share with you a little bit about myself, and then we'll move on quickly and kind of why I'm excited to bring these free monthly webinars to you. So I'm a clinical psychologist and also the director of training at the Feeling Good Institute. And I was originally trained by really some of the world's best and most prominent CBT leaders in our field in Boston and New York and Philadelphia on the East Coast. But my effectiveness as a therapist, I believe, really dramatically increased when I started working with David Burns out here in California over 17 years ago. And the framework that David Burns created, which is called TEAM-CBT, really changed the way that I practice. It taught me kind of step by step how to make therapy more effective. And so I'm excited to share his approach with you in our monthly webinars and in our Core Skills for Effective Therapy course and our Fast Track to Level 3 course, which I'll share with you at the very end of the webinar if you're interested in learning more from us. So that's just a little bit about me. And now let me introduce to you this month's awesome presenters. I'll start with LJ Davis. LJ is a licensed professional clinical counselor who practices across California, North Carolina, and Georgia, boasting over 16 years of experience. And LJ specializes in sleep and insomnia, social anxiety, and depression. And as a level 4 TEAM-CBT trainer, LJ not only treats clients, but also trains therapists globally. Next is Kevin Cornelius, and Kevin's a licensed marriage and family therapist and also our intensive therapy manager at Feeling Good Institute in Mountain View. And Kevin has been providing CBT to teens and adults for 9 years, and he was also trained in the TEAM-CBT model by David Burns at Stanford University. And Kevin currently provides outpatient therapy to adults across the lifespan who struggle with depression, anxiety, insomnia, and relationship problems. He's a level 4 advanced therapist and trainer in TEAM-CBT, and also has been certified as a CBT for insomnia therapist by Dr. Greg Jacobs of Harvard Medical School. So you're definitely in for a treat with LJ and Kevin. And so I'll turn it over to LJ and I'll come back on with you guys for Q&A.
All right. Thank you so much, Jill. And Jill said she was going to introduce herself and really told a lot about TEAM as well, which I think was great. But I'll just say what an honor it is to get to work with Jill, who has had such an influence on the field and trained with such incredible people. So thank you, Jill. And we can see here that the plan for today starts with introductions, and we're through that part now, so that's great. And then in just a minute, I will turn things over to Kevin, and he will take us through the basics of CBTI, getting some of the definitions that we need to know to be on the same page together, as well as going through some of the basic tools of CBTI. And then we'll look at one of those really basic tools, the sleep diary, together. Excuse me. Which we'll use for information gathering, and then also to see how to set up and expand the sleep window, which will be the second part. And then, as Jill said, we'll save some time for Q&A at the very end. As we're going along, though, if you have questions that come up, I'd recommend chatting those to Jill, and then she'll be gathering those questions up and collecting them, so we'll have them there at time for the Q&A. And then here are a couple of our learning objectives. These are the two official objectives, though I hope you will learn a lot more. We'll be going over lots of things. So the first one is to identify 2 contraindications for sleep quality training. And the sleep quality training, which is also classically called sleep restriction, is one of the main things we'll be focused on, but it's important to know these contraindications. And then we'll also make sure you know how to teach clients how to complete a sleep diary going forward. And so now I'm going to turn it over to Kevin, who will start us off with the basics of CBT for insomnia.
Okay, great. Thank you so much, LJ. And the first thing that we want to do is just talk about a definition for insomnia. And this is pulled out of the DSM, I believe, where we have a complaint or dissatisfaction with sleep quantity or quality. And there needs to be one or more of the following symptoms present: the difficulty initiating sleep or maintaining sleep, and that's those problems are often characterized by frequent awakenings during the night, or problems returning to sleep after awakenings. And then many people will wake up too early and they won't be able to go back to sleep. And these one or more of these symptoms would need to be present at least 3 nights a week for 3 months or longer, and cause a lot of problems in life. It's important to rule out other disorders that might be responsible for the sleep disruption. And of course, if there's substance abuse or other life circumstances that could be contributing to the sleep problems, we want to take that into consideration before making this diagnosis and choosing to use CBTI for treating the sleep problems. Okay, so we want to think a little bit about how much of a problem is insomnia with the general population. And we've got some statistics here from the American Academy of Sleep Medicine. 30% of US adults have some symptoms of insomnia, and 10% have insomnia severe enough to have daytime consequences. And those consequences would be on a person's mood, their level of productivity, and it also can have a big impact on relationships. So we can see that insomnia can really impact people in many areas of life, and is a serious problem that we're happy to share some wonderful techniques for helping people with these problems. And when we're using CBT for insomnia, we're going to be looking at these 4 primary areas. So to begin with, cognitive restructuring. And many of you may be already familiar with CBT, cognitive therapy. Cognitive restructuring for mood problems is when we change the way that we feel by changing the way that we think. When we're talking about insomnia, we're talking about changing our sleep problems by addressing negative sleep thoughts that exacerbate and prolong sleep problems and really turn them into a chronic learned insomnia, because those of us who are struggling with insomnia are telling ourselves things that are disrupting our sleep. So part of the CBT for insomnia program is going to be doing some education with the client to help them understand that they may have some beliefs about sleep that are getting in their way. A classic one would be if somebody is not getting 8 hours of sleep per night, they may be stressing themselves out by saying, oh no, I can't be healthy if I don't get 8 hours of sleep a night. And the reality is that most people get between 6 and 8 hours. That's a healthy range of sleep. And understanding that and taking off that pressure to always get 8 hours is an important way of addressing a negative sleep thought that leads to an insomnia problem. And there are others, and when you probably will get additional training before practicing CBTI, you'll learn other sleep thoughts to look out for and how to counter them. With stimulus control, what we really want to do is create a mental connection to the bed as a place for restfulness and sleep. That's what we really want, is that mental association. We don't want the bed to become or remain a source of struggle and frustration. And so we're going to be working with the client to, for instance, save the bed for sleep and sexual activity only. And some people have developed some pretty unhelpful habits of working in bed, reading their phone in bed, maybe watching TV, whatever they might be doing. That's contributing to the problem of that stimulus control would solve. Sleep quality training is hugely important. This is it's often been referred to as sleep restriction or sleep rescheduling. And that's where we're going to be addressing the amount of time that's being allotted for sleep to make sure that there's a higher percentage of time where the person is sleeping and not in bed awake. And that's by reducing the amount of time in bed, we can help the patient build a sleep drive and improve their quality of sleep. And this is one of those areas where probably all these areas, patients are going to give a little pushback and have a little resistance to the methods that we're going to be introducing. And if you look at the previous webinar that LJ and Anastasia Morrison and I did on CBTI earlier in the year, which you can find on Feeling Good Institute's website, and I believe Jill is going to put the link for that in the chat. We addressed that pretty well in that seminar, where methods of TEAM-CBT that you can use to increase motivation and lower resistance to things that are difficult to do, like sleep quality training. And then the final piece would be sleep medication tapering. The reason why we mention that is because there really is, unfortunately, no medication that's really effective for treating insomnia. They all have drawbacks, often a long half-life that causes drowsiness during the day. They're often addictive, and they also do not address the causes of insomnia, which are negative sleep thoughts and negative sleep behaviors. And so when the person stops taking the medication, they go back to their sleep problems. So, for me and personally, and probably also LJ, I'm not a medical doctor, so I don't, set a medication tapering schedule without coordinating with the patient's doctor and getting a buy-in and setting up what that program is going to be. But it has to be included if the CBTI is going to be effective. Okay. Now, we do want to speak a little bit about sleep apnea, which we would want to rule out before we would be using CBTI. It's a dangerous disease with important implications for stroke or heart disease. And there's this great tool called Stop Bang. That's an acronym that I won't describe the whole thing to you, but there's a link that LJ has provided at the end of the presentation where you can see this tool, but it's a really great brief test that you can have somebody take in order to assess if they need to have a sleep study to see if they are actually struggling with sleep apnea.
All right, thank you so much, Kevin. I really appreciate that. And one thing Kevin said as he was talking there briefly is that it would be a good idea to get more training on CBTI. Like today's training will give you some great ideas and teach you how to use some of the tools. But to really be able to put the model into full effect, I know the training I did was a 3-day training. So there's quite a bit more to cover, but we do want to share these tools with you as well. So the first thing, before we jump into the sleep diary and sleep quality training, we do want to look at a couple of the contraindications. As we noted earlier, sleep quality training is sometimes called sleep restriction because we are going to tighten the amount of time the patient or client is in bed. I've also heard it called time in bed restriction, which is probably the most accurate name for it. Though still a little bit off-putting for people, so that's why I like sleep quality training better. But the first one is bipolar disorder, and the second one is epilepsy. And both of these, having a little bit of sleep deprivation can sometimes have pretty significant consequences. And so we want to be mindful of that. And the sleep quality training time in bed restriction can lead to a slight loss of sleep at times. And so we want to be aware of that. And it's a loss of sleep that then we will build from to get more sleep. But we would not want to accidentally set up a bipolar person to have a manic episode from having that extra sleep deprivation. And the same thing, someone with epilepsy, sleep deprivation can increase the chances of seizures. So just a couple of things we would want to be careful of. The good news is, with those populations, the other aspects of CBTI can still be helpful, and we can do some sleep scheduling and sort of sleep structuring with them, just not quite as intensive an intervention as the full sleep quality training that we're going to describe today. And then we'll start off talking about the sleep diary and sleep quality training by talking about the rationale for it. Why do we want to do this? And you can see on the screen here, because people with insomnia a lot of times are spending a lot of time in bed. The strategy makes perfect sense to me, and it's one I've engaged in the past when I've had sleep difficulties of like, if I'm not getting enough sleep, maybe if I spend more time in bed and give myself more opportunity, I'm going to catch more sleep. You know, if I go to bed especially early, that was my vulnerability. If I go to bed especially early, then I'm just going to, really make up for the sleep I've been losing tonight. Or for some people, I'll just stay in bed longer in the morning and also try to make that up. And the problem is, when people are doing that, they tend to have long stretches of time where they're sort of going in and out of sleep. And so they're getting a really low quality sleep, and they're getting a light sleep. And Kevin mentioned the phrase sleep drive earlier. That light sleep will reduce their overall sleep drive. But then when they get into bed, they won't have as much sleep drive, they won't sleep as well, and they won't sleep as deeply. If we can really concentrate that window of time that they're in bed, they're more likely to get the deep and restful sleep that they want to. I have a couple of different metaphors I use for sleep drive, and one of them is like it's the gas in the tank that will drive you through the night. And if you're spending extra time in bed, you're not putting gas in the tank during those times. In fact, you're maybe even taking gas out of the tank if you're going in and out of sleep. And so we want to eliminate that, to really have a full tank of gas that can drive our clients into a really good state of sleep that next night. You see here that a little bit more on the rationale. As humans, we have three main types of sleep. When I first was trained, it was called light sleep. Sometimes people now call it core sleep because it makes up actually the bulk of our time in bed. Sometimes the majority, sometimes a plurality, just depending on what's going on. And then there's deep sleep and REM sleep, and all three of them are important and have their function. But when we wake up and really feel refreshed, it's usually because we've gotten more of that deep sleep. And so we really want to increase their sleep drive so that when they go to bed, they have the best opportunity to really get that good deep sleep. They'll also get more REM sleep, which is also important for memory and other things. And one of the things that's really interesting about sleep quality training or time in bed restriction is it's not uncommon that our clients will come back even on the first week when they are obviously spending less time in bed and might even look like they're getting less sleep. And they'll say how much more refreshed they feel, even though they're getting less obvious sleep. The sleep quality is already improving and they feel more refreshed by going through this intervention. And so the first step we want to go through with our clients is to get them to fill out a sleep diary. When our clients first come in, I'm sure we've all had clients who've talked about their sleep this way. They'll say, oh, I never get more than 4 hours of sleep per night, or I never get more than 5 hours of sleep per night. And there's a good reason for that. They're not being dishonest, but our memories for our sleep are not very good. And so when we look back over the week, we'll just kind of pick what seems like the overall pattern to us and not notice how much variation there is. So that the first thing I want to do with a new client who's wanting to work on insomnia is get them started filling out a sleep diary. And you see an example here on the screen. And Kevin mentioned earlier at the end of the presentation and the slides you can get from the training site where you logged in today, there'll be a link for resources and you can get the sleep diary there. You can also get the stop bang assessment or rather screening tool for sleep apnea. And there's actually lots of other tools there too that we won't be going over in the workshop today or won't be talking about. But this is going to be our main information gathering tool. And I just want to go over it really quickly because it's pretty straightforward, but there are some places that are sometimes a little bit unclear. And so if you look at the first two boxes, the first one is what time did you get into bed? And then what time did you try to go to sleep? And this is going to be really helpful when we first start off, not just with our sleep quality training, but also with some of the stimulus control that Kevin was talking about. Because if we see our client, this example client on this one is getting into bed at 10:15, but not trying to go to sleep till 11:30. So there's something they're doing there, and we can target that in the stimulus control. There's also a fair chance that during that time, they may be dozing in and out some and not even realize it. And so that's another reason we'd want to be aware of that time when we're thinking about their sleep window and sleep efficiency. So there's the time they got into bed, there's the time they actually tried to go to sleep, and then there's how long did it take you to fall asleep? So of course, we all know when we lie down and try to go to sleep, we usually don't fall asleep instantaneously. So that's just about that gap between the time we tried to go to sleep and when we actually did go to sleep. And we'll talk about some keys to the sleep diary in just a moment about how we want our clients to think about that and record that information. Then the next one is how many times did you wake up, not including your final awakening. And so just how many times did you wake up in the night? And in the example we have here, 3 times. And then the next box is make your best guess. How long did those last? So if you were to add those 3 times together, how much did it last for? And you see for this person, it was 1 hour and 10 minutes. And then 6 and 7 are kind of like those first 2 at the top. What time did you wake up for the last time? And then what time did you get out of bed? And there's another place where we might be curious about stimulus control, or it might be that our client here is like staying in bed to try to catch extra sleep, like we were talking about. But we can see they woke up at 6:35, but then they stayed in bed until 7:20. And it's recently turned cold here in Georgia. Sometimes I want to do that too and just like enjoy that cold. It's a little hard, or enjoy that warmth. It's a little hard to get out of bed. And then for somebody who's not sleeping well, there's also that temptation or that desire to try and catch as much sleep as we can. And then you see the last 2 boxes here. One is just a subjective rating of what their sleep quality was like. And in this case, the person said it was poor that night before, which can make sense when they were awake so long and it took so long to go to sleep. And then the bottom box is for comments. And comments could be anything that might have an effect on their sleep. So sometimes if a client is taking sleep medicine, or if we're in that sleep medicine taper, I'll have them sort of making sure to let me know what they're doing with their medicine in that box. You see this person said I had a cold, which may, have affected their breathing or something that could affect their sleep. Caffeine consumption, alcohol consumption, things that were particularly stressful, the kids were up all night, whatever it might be, could go in that box. That would also be helpful information. And then here are just a few keys to the sleep diary. The first one is we want them to keep it out of the bedroom. Some people will really want to give us the best information they can, and I love that. But if they're keeping it in the bedroom and trying to take notes on it at night, that's actually going to be disruptive to their sleep. So we don't want them to do that. And at the same time, our sleep memory fades quickly. Like I was saying before, when clients come in and just reflect on the previous week's sleep, they'll have a hard time really giving you an accurate report. You can think of this the same way as like trying to remember a dream. When I first wake up, I can usually remember my dreams fairly well, not always great, but by lunchtime, I couldn't tell you what that dream was. And it's the same thing with our sleep. As the day goes, our memory of it will fade. So we want them to do it as soon as possible in the morning. And I usually suggest to clients that they put it somewhere where they'll see it early in the morning and remember to fill out the sleep diary. And then number 3 is one that is a little tricky for people sometimes. We don't want them to have clocks that they can see in the bedroom. So if you think about it, there were a few spots on there where we asked them to put specific times. But once they try to go to sleep and once they wake up for the final time, or between the time when they try to go to sleep and when they wake up for the final time, we don't ask for specific hours. We want them to guesstimate, how long did it take me to fall asleep? So if I went to bed and I went to sleep easily, maybe it was 5-10 minutes. If it took me longer, then I may be like, about a half hour, about an hour. And that goes into number 4. We actually don't want perfectionistic data. We would rather have their impressions. At its heart, insomnia is a subjective disorder. And so we're really wanting to get what their subjective experience is when they're filling out the sleep diary. And that's what's going to be most helpful for us to understand what they're experiencing and then be able to target our interventions in the best way. And then point 5 here, we'll use the information we get from the sleep diary to calculate sleep efficiency, which is just basically how much of the time that they're in bed are they actually sleeping, and then also to set up their sleep window. And now Kevin and I are going to do a little bit of a role play about the sleep diary and how we would present it to a client. So, Kevin, you ready to unmute and we'll get started?
You bet. Yes.
Okay, awesome. Well, Kevin, it's great to see you again here today, or today maybe for the first time, actually. And I'm so excited to help you get the better sleep that you've been wanting. I know how much of a struggle it has been, and you've told me you really want to be sleeping better and feel well rested. And I want to introduce you to really what's going to be our first tool and kind of our anchor as we go through a lot of the steps in this process. And it's called a sleep diary. And it's going to be how we find out with as much detail as is possible, and maybe even as is desirable, about what's going on with your sleep. And the first thing I want to talk about is just how to approach the sleep diary. We don't want you to have it in the bedroom with you at night. I don't know if you're the sort who would be tempted to do that, so you could get good information, but we do want it somewhere where you'll see it first thing. So where do you think you could put it so that when you get up in the morning, it'll be available to you?
I think I could have it on the counter in the bathroom.
Okay, awesome. That works. I
Mhm.
myself am too messy when I brush my teeth, and I think my sleep diary would get wet if I did that. But if that works for you, that's great. If it does prove to be a problem, other places sometimes people put it's like on the kitchen counter if they make coffee first thing in the morning, or on the table somewhere when they get up. So that's great. The bathroom sounds wonderful. And then the next part you'll see on here, we'll go through what each box is about in just a minute, but you'll see that it asks about specific times, or it asks about how long you were awake or how long it took to fall asleep. And what's going to be a little bit strange is I'm going to ask you not to look at any clocks while you're doing that. And can I just check in? Do you usually have clocks in the bedroom?
Yeah, I have like a stand for my phone, and it makes this nice clock there that I can look up and see.
Okay, that makes good sense to me. I'm guessing that's probably like your alarm too, and make sure you wake up in the morning
Yeah.
and those sorts of things.
Hmm.
Well, for most people, I don't know if this is true for you, when they're having problems with their sleep and they wake up, at 2:30 in the morning, and they look over and see the clock says 2:30, it's kind of stressful for them, and actually makes it a little harder for them to go back to sleep. Does that happen for you when you wake up? You're like, maybe feeling frustrated or anxious about your sleep at that point?
That's true. Yeah.
Okay, so actually what I want you to do is when you go to bed tonight and going forward in our work together, can you just I don't know if you can put your phone face down so you'll still be able to hear the alarm. You could put it in another room if you don't need the alarm, but I know that may not be practical. Or you could turn it around so that it's facing away from you. What would be a good solution for you with that clock?
Yeah, I can just turn it around. That would be fine.
Okay, awesome. And then when you do that, we just want you to use your memory as best as possible to get these times right the next morning. So we're
Mhm.
not looking for super precise data. We want really just what it feels like to you, and that will give us our best idea
Okay.
than looking at the clock. Does that make sense?
It does, and in fact, I can probably just rely on my Apple Watch because it tells me, sleep data, so I can know how long I was asleep and all that.
I'm so glad you brought that up, and I love that idea. It kind of shows me how much you want to really get the data right. And at the same time, weirdly, it's better if we get your impressions than if we get that data from the sleep watch. And there's a couple of reasons for that. One is I really want to know what your experience is, and getting the data from the sleep watch doesn't quite capture that as well. The other thing is the watches are not as accurate as people taking the diaries tend to be. I don't know if you've had this
Mm.
experience, but I know I was talking to a friend of mine, and he said, he could be sitting and reading for a while before bed, and then when he goes to bed, when he wakes up the next morning, the watch will say he was actually asleep during that time he was reading. So the watches are not super accurate, and so they're kind of fun to look at and whatnot. But for the sleep diary, if you could give me your experience, that would be better. Would that be okay for you?
Sure, I can, yes, it sounds like that's the best way to go. So,
Okay, Awesome. And then let's just talk a little bit about the different sections of the sleep diary. You see there's a little difference in the first two boxes. The first one is about what time you got in bed. So if you're getting in bed and then like watching TV or reading or email, whatever it is you might do, go ahead and put that down as the time you got in bed. And then the next box is when you've really shut everything down, you've put the book away, turned off the TV, turned off the lights, whatever you do to actually start trying to go to sleep. That's the time we're wanting to put down, is when you try to go to sleep. Does that make sense?
Yeah.
Okay. And then the next boxes are pretty straightforward. How long did it take you to fall asleep? Again, your best memory. And then how many times did you wake up in the middle of the night? And that's not counting when you woke up to stay, but if you woke up for 5 minutes, that would be one. If you woke up for an hour, that would be one, as long as you went back to sleep afterwards. And so just count how many times that was. And then below that, make your best guess as to how much time those all added up to. And put that in that box. And then the rest of it is pretty straightforward. We want to know what time you woke up in the morning, what time did you actually get out of bed, because a lot of times there's a gap there. And then tell us how good the sleep was, and anything else in the comments that, were there cats screaming outside your window all night that were waking you up, or anything else that might go in the comments. Caffeine consumption, if you've had alcohol, sometimes it can help us fall asleep, but then we end up waking up later as a result, so it can be disruptive to our sleep too. So just anything that might have affected your sleep, can you put that down in the comments box?
Sure.
Okay, I'm really looking forward to getting this information, Kevin, because it's going to just like launch our path forward. And so next week we'll talk some more today about other things you can do, but starting next week, then we can really get into the sleep quality training and some of the other stuff that'll be really helpful for you. All right, awesome. Thank you, Kevin, for that demonstration. And then once Kevin comes back, or our client comes back, and we're just going to use this sample information right now. And I want to sort of knock a little bit on the table and say, this is a good time if you've found yourself with your attention waving. I know that I've had that happen sometimes. We're about to do a little bit of a math calculation. And if you've zoned out, this might be a good moment to tune in and be as clear as we can. So we're going to talk about how to calculate sleep efficiency, which is one of the core ideas of the sleep quality training. So the first thing we need to do is find out how much time was the client in bed. And we can see this person got into bed at 10:15 and they got out of bed at 7:20. And just a little simple, math, I was able to figure out that's 9 hours and 5 minutes. And I changed that into purely minutes because minutes make it easier for us to do calculations with. And then the next part is the time asleep. And so here we want to start with the time they started trying to sleep until their final awakening. So it was 11:30 p.m. They started trying to sleep, and their final awakening was 6:35. So that's, I do the math there, and I get a total of 7 hours and 5 minutes between 11:30 and 6:35, which I then convert into 425 minutes. And then we need to figure out how much time they were awake during that window. So if we look at box 3, it took them 55 minutes to fall asleep. And then in box 5, they were awake for 1 hour and 10 minutes during their 3 awakenings. So if we add those two together, 55 minutes and 1 hour and 10 minutes comes out to 2 hours and 5 minutes, which is 125 minutes total. It's worth noting too, all these calculations, there are several of them, but they're all things we can perform on the calculator that's on our phone or any other calculator we might have. And then the last part is we want to get their time asleep. We subtract that time that they were awake, that 1 hour and 25 minutes, from the time they were trying to sleep, which is 425 minutes. So we see that comes out to 300 minutes or 5 hours. And then to get the sleep efficiency, we just do a division where we divide the amount of time they were asleep by the amount of time they were in bed. And that comes out to 0.55, and that's 55%. So we now know, at least on this one night, this client had a sleep efficiency of 55%. And then the next part is how to set a sleep window. And so I've made up a sleep diary here for somebody named Alex. And we can see that Alex, over the course of the week, we won't do all the math together again to go through all this, but Alex averaged 5 hours and 30 minutes of sleep per night. And to get the length of his sleep window, then we're going to add 30 minutes on to that 5.5 hours. And there are a couple of reasons why we do that. One of them is that most people actually underreport their sleep a little bit. When they're spending that extra time in bed and getting those light sleep moments or some of those kinds of things, they probably will not put that in the sleep diary because they don't even realize they're having like little 2-minute naps off and on through that time. Also, we want to give a little bit of a cushion there. If Alex is sleeping for 5.5 hours a night, even though we're going to do this time in bed training, the sleep quality training, he's not going to instantly fall asleep when he goes to bed, and he may still need to wake up and go use the bathroom at some point in the night, or whatever it might be. And so we want to give a little bit of cushion there beyond the 5.5 hours to get it up to a sleep window of 6 hours. And you also see on here that I never give an initial sleep window below 6 hours, and rarely do I give a sleep window at all below 6 hours. One of the things we know about sleep is that to be healthy in a physical way, we need about 5 hours and 30 minutes. And the vast majority of people are actually getting that, even if they don't recognize it. And so we don't want to do anything that would keep Alex from getting that 5.5 hours of sleep if possible. So we add that 30 minutes to get 6 hours. And then we know 6 hours is how much time we want him to spend in bed. And if we look at his sleep diary, we can see, 5 mornings a week, he's getting up at 6 a.m. but not getting out of bed until 6:30. And so we can just have a little conversation with Alex. And we want to find out what's the earliest time that he has to get up. And that's going to become our anchor. And I'll ask Alex to make 6 a.m. or 6:30 a.m. We're imagining here that he chose 6 a.m. So I'll ask him to say, okay, we're going to make 6 a.m. your wake up time 7 days a week. We want to keep that consistent. That's going to be our anchor point. And then his earliest bedtime, we just count back 6 hours, which the math is very convenient here. If we take away 6 hours, that basically means he can go to bed at midnight, which you'll see is much later than when he was getting in bed some nights. So this is a pretty good sign that this is going to be a helpful intervention for Alex, that we'll be able to, he'll be really good and tired when he gets to that earliest bedtime. And my best guess is that he will then start to get that increased quality of sleep that we're really going for. And now Kevin and I are going to do another little role play where we'll sort of talk about the sleep window with the client and discuss the findings of the sleep diary and set the wake time and bedtime and some of those things. So you ready, Kevin? All right, awesome. Well, Kevin, welcome back this week. And thank you so much for filling out the sleep diary. It's really going to give us some great information to work from. And, looking it over, I don't know if you did any of the math to figure this out, but it looks like on average, you're getting about 5.5 hours of actual sleep per night. Does that sound about right to you?
I think that's true. Yeah.
Okay. So what we're going to do, we're going to use that 5.5 hours to set your sleep window, but we're actually going to give you 30 bonus minutes on top of that. So your sleep window will be 6 hours, and that's how much time we want you to start spending in bed at night. That way we'll really improve your sleep quality. And you'll notice that you've been spending about 7.5 to 9.5 hours in bed most nights. You're spending like an hour and a half, sometimes even, or no, sorry, you're spending 2 hours more in bed than you're asleep most nights, and sometimes even more than that. And what happens when we're in bed so much more than we're sleeping is that the quality of our sleep really decreases. And what we really want to do is get a really powerful sleep drive. And that's going to improve the quality of your sleep. You won't have lots of light sleep where you're kind of going in and out and things like that are often happening when you're in bed as much as you are. But instead, you'll have a big solid chunk of sleep. And the way that we do that is we really want to maximize your sleep drive. And we can think of your sleep drive as being like a balloon. For some reason in my imagination, it's always a red balloon. But anyway, you'll have this nice red balloon. And as soon as you get out of bed in the morning and start doing things, it's like we're blowing up that balloon and we're just filling it full of air, filling it full of air. And we want to keep doing that throughout the day. And we don't want to get in bed before you're ready to go to sleep, because anytime we spend napping is also something we'll talk more about. We don't want to do any napping during the day right now. There's certain situations where we may, but we'll talk about that. But when you get that balloon really big and full, it's got lots of air in it, then at night, when you let go of the neck of the balloon, it's going to have enough air in there to really propel you to sleep more through the night than you have been, and you'll get bigger chunks of higher quality sleep. Does that make sense?
Yes, it does.
Okay. Well, great. So we're going to use this time that we talked about, this 6 hours, to set you a new sleep window. And if you think about the 7 days of the week, which day or days do you have to get up the earliest?
Yeah, it's like weekdays. I have to get up at 5:45.
Okay, so on weekdays you have to get up at 5:45.
Mm-hmm.
And so then what I'm going to ask you to do, and this is one of the parts that can be challenging, is to get out of bed at 5:45, 7 days a week, so that we really have a consistent sleep schedule.
Mm.
I know that's a big ask, and I wouldn't make it if I didn't know how important it is. So is that something you think you could do? Is even on the weekends when you've probably been wanting to sleep in a little bit more, get up at 5:45 so we can really get your sleep problems taken care of.
Yeah, it's gonna be hard, LJ, but I trust you. If you say that that's necessary, I'll do that. But I do like my extra sleep on Saturdays. But
I feel you, and my real hope is that we'll take care of your sleep challenge, and eventually we'll get back to what I call sleep in the wild. This is not a permanent lifestyle change, but this is a necessary step to get over the insomnia, and then you can start to loosen up on some of these once we've accomplished that. So I'm glad to hear you can do
yeah.
that. And your sleep window is 6 hours. So if you're waking up at 5:45, we're just going to count back 6 hours from that, and that means 11:45 p.m. will be your earliest bedtime. And I want to be clear with you what I mean when I say earliest. When you get to 11:45, if you're not sleepy, we still don't want you to get into bed. So a couple of things about that is sleepy means like really genuinely sleepy. Like I'm having a hard time holding my eyes open, or sometimes even my head is starting to nod. I really feel like I'm about to fall asleep. Not just tired, not just like I'm kind of yawning a lot, because I'm sure if you've been among a group of people at 5 o'clock in the afternoon, if one of them yawns, lots of people will yawn, but they're not all ready to fall asleep. So yawns are not a good indicator. Does that make sense?
Yeah.
Okay. Um, and then, but if you are sleepy, then that's when you can go ahead and get in bed. And my experience
Mhm.
is for most people, the harder part is actually to stay awake until 11:45. Like you've been getting in bed, at 9:30 a lot of nights, and I imagine you're really sleepy at that point. So can we talk about what you can do to stay awake until 11:45? And I could give you some ideas if you want. Some people work on a puzzle or do a little light housework. Or I know for me, like I enjoy watching TV, and I don't want to watch anything too stressful at that time. But if I sit on my nice cozy couch, I'll be out. It doesn't work for me to do that. But we've got some bar stools that are wood and that kind of got me sitting up in a less comfortable posture. I can sit and watch TV there, or even stand up. So what do you think will work for you to help you make sure you can stay awake until 11:45?
Yeah, I think I'll go for the light housekeeping job, and I'm sure my partner would appreciate that, and that might make things a little more harmony at home too.
Okay, awesome. Well, that you get a two birds with one stone there, so that's great. Yeah, just work on that housekeeping there. And um, well, I will look forward to seeing you next week. Of course, keep keeping the sleep diary, so we get the information of how this goes this coming week, and I look forward to see how that goes for you.
Great.
All right, thank you so much, Kevin. I'm seeing our time. This is going a little bit slower than I'd hoped, so I'll try to be quick and thorough going forward. So once they have started the sleep quality training, then of course we start with that compressed window of time for sleep, but we don't want to hold them there. We're hoping that it will get to grow. And sometimes that happens quickly, and sometimes it takes a little bit more time, but just some guidelines to think about. Each week, if their sleep efficiency is 85% or greater, then we can add a little bit of time to their sleep window. And then 15 or 20 minutes are my typical additions there. And when I first say it, 15 minutes doesn't sound like much, but if you think about like 2 weeks, then they have a half hour more sleep than they were getting when they came in. And by the end of a month, it could be an hour more sleep. And of course, that can keep going depending on where things started and what their ultimate sleep need is. Um, if the sleep efficiency is 80 to 85%, I usually just hold steady there. Sometimes it takes a couple of weeks or a little bit longer even for everything to take effect. And we may need to talk more about stimulus control or some of the sleep thoughts that are getting in the way. Use some of the other CBTI tools as well as the sleep quality training to start getting that effect. And if their sleep efficiency is less than 80, we may consider shrinking the window. So, like I said before, I'd be hesitant to go below 6 hours, but if their initial sleep window was maybe 6.5 hours, then they're not getting the sleep efficiency we want. We may want to actually take away 15 minutes to try to really help them get that effect and start moving in the right direction. And then over time, what almost always happens is their sleep window will start to grow because they'll be getting that good sleep efficiency, and we can add on more time. And as that happens, then we want to start paying attention to daytime fatigue. Are they still feeling as tired as they did during the day? And when we get to a place where they're not feeling tired in the day and they're not sleepy before bedtime, then we may have found their sleep need. And like Kevin said earlier, we have this cultural myth of like 8 hours of sleep is the right amount of sleep. But the truth is that's an average. And that means, some people need 6 hours of sleep. There's some people who need 9 hours of sleep. There are some outliers who go even outside of those two things. So by using the sleep diary, we're going to find out what this person's actual sleep need is. And that'll be a really helpful piece of information for them as they're going forward. And I put in a couple of questions that we got before when we did our earlier one, because we didn't get a chance to get to them. We kind of already addressed the Apple Watch or Fitbit question in the role play, but again, subjective experience and the accuracy of those devices are reasons we might not want to do that, or why I wouldn't want to do that. Another question, which I thought is a really good one, is which should I treat first, insomnia or a mood disorder? And my thoughts on that is that we have to use our clinical judgment there. Depending on the severity of the mood disorder or whether it's presenting risks to their health and safety or to the health and safety of others, of course, we'd want to take those things into account. And then there's some amount of like, what are they more motivated towards is also a helpful thing to take into account. And it is true that improving sleep has been found to help people reduce depression symptoms. So, that may be a way to think about it. And then just in my experience that I can often do a combination, like I may need to spend 1 or 2 sessions really getting the CBTI part of things rolling. And then once we have that, we can sort of keep following up a little bit while we also do some mood work as part of our work together. And then the last one is, what about CBD or other supplements? And as Kevin said earlier, neither he nor I are doctors, and so we would not suggest people do any particular sort of biological intervention that's beyond our scope of practice. So I just steer clear for those reasons. Also, though, I'm pretty skeptical of over-the-counter supplements, including melatonin. They're pretty poorly regulated, and there've been lots of studies that have come out of them not actually having in them what they say they have in them. Sometimes having other things in them, sometimes just not having the active ingredient at all. The dosages being really variable. So I don't mess with supplements. If a client's already taking them, like I don't necessarily like tell them stop taking that thing right away. But I will want us to start talking about that. And in the same way that we might do a medication taper, we might want to consider that with other supplements they're taking. And then about CBD specifically, I don't have as much information about it as I would like, but I know THC, comes from the same plant, reduces people's REM sleep. And sometimes people use it for that reason. If they have nightmares, they'll be using THC to reduce that REM sleep. But it does create a problem of dependence, because when we have a drug suppressing our REM sleep, when we don't use that drug, there'll be a bounce back. And so people who are using THC to avoid nightmares will get just a flood then of dreams and nightmares when they stop using it. And so that's something I would also want to take into account. Then we promised a slide with resources earlier. This will be in your package, so I'm not going to go into a lot of detail here, but I do want to highlight the top one, cbtiweb.org resources assessment. That's where you'll find the sleep diary, the stop bang, and like I said, lots of other tools. There's also Insomnia Coach and Doze app. Both of those are apps that have been designed with CBTI principles. And in the book, I usually get my insomnia clients to read is called Good Night Mind. It's by Colleen Carney. She's an excellent clinician around sleep, and she's who I got most of my CBTI training from. So that said, I'll move us over to Q&A time.
Wonderful. You guys did a fantastic job. I am actually truly impressed at how much information you were able to pack into such a short period of time, and also your demonstrations, I thought, brought things to life so effectively. I did want to just share, I have a couple people who said the same thing, and someone said, I love that idea of sleep in the wild, LJ. That will really make folks feel that they don't have to be in sleep scheduled jail forever, which I thought was great. Let me see, there was one more. Oh yeah, just wanted to say it was great training. Lots of high quality info in a short period of time. People saying they really like the idea of the incremental increases to achieve sleep efficiency. But I do have lots of questions. A lot of them you actually eventually answered. So if people sent me questions that I'm not reading, it's because the answer to the question was covered already in the content. I thought this was a good kind of challenging question. They were asking about sleep efficiency percentage. This question relates to a person who's been doing sleep quality training for a while in therapy, and they adhere well to the allotted sleep window and stimulus control rules, but still tends to have at least one night a week with really little sleep, 0 to 3 hours of sleep, which really skews the average hours slept for the week. It makes it difficult to increase the sleep window with this data. Do you guys have any suggestions?
Well, I'm really a little bit hesitant to weigh in. I'll share some thoughts, but it sounds like they're working with a therapist who knows them a lot better than I do. And so
Exactly.
I don't want to pretend I'm an expert in this person. But it is a place where I sometimes will be a little bit flexible. If there's like one night that's an outlier, one, I would be curious if it's the same night and patterns and some of those sorts of things. If it's the same night every week, it would be curious to find out what's happening on that night. Assuming that's not the case, there's part of me that might try increasing the sleep window anyway. If they're getting great sleep efficiency all the other nights and there's one night a week, people have one night of bad sleep, and that's not always the end of the world. So that's probably the approach I would take. But again, I don't know all the ins and outs of what's happening with that person. I don't know. Do you have any other thoughts, Kevin?
I love what you said, LJ. I think that you can experiment with it a little bit, right? Sometimes we add time back onto the sleep window to see how it does affect the sleep efficiency. And if it doesn't have a negative impact on it, then you can even add a little bit more. So we're always playing around with it a little bit anyway, once we start adding time back on. So you can't really do permanent harm.
Great. And just also, lots of people started sending very specific clinical case questions, which I'm not going to read because, again, I think we always need to be careful about like enough context and things like that. But I have some other questions that are more general. So a bunch of people actually said, do you recommend using the app, the CBTI Coach? It does the calculations for you. So still, it's not like a watch-based thing where it's collecting the data, but it's where you input the data. Just wondered if either of you had experience with that, and if not, that's okay too.
I have used it a little bit, and I think I've reverted back to the sleep diary just for my own comfort. And so if you're using the CBTI Coach, yeah, there's 2 insomnia apps created by the VA, and that's one of them, and they're both really high quality. So if you're finding ways to work with that and get the information you need as the therapist to help your clients from it, then I'd say that's great. Go for it.
Okay, awesome. People are asking me about the CE survey. That'll be dropped in the chat box at about 5 of the hour, and you'll fill it out there. LJ, someone said that you mentioned that naps are okay in some situations. What are those situations?
Well, for me, it's about safety. So like I had a client once who had a long drive at some point in the day, and if they have a long drive and they're likely to fall asleep on that drive, I would rather them take a nap. It may have some effect. It may cause problems with the sleep quality training, but it's going to have a much less effect than them having a car wreck because they fell asleep while they were driving. So safety always comes first. That's one of the situations. And then there are sort of different information about naps. Sometimes people say if they're early enough in the day and short enough, we can do some of those. But I typically, unless there's a compelling reason, try to steer clear of them.
Yeah. Okay. And then we had lots of questions about sleep, about stimulus control and what can we include. So it's funny too, because I'm sure people are asking for themselves, like, is coffee or breakfast in bed okay? And that the other one though that I think is a serious question is, can people read an actual physical book in bed to relax before sleep? So can you guys say a little more about the stimulus control?
I feel a little worried that I'm hogging all the answers. So yeah, I was gonna.
Oh, I'd be happy to answer that one.
Yeah,
Sure.
please, Kevin.
Yeah, I would say that, when somebody's really struggling with insomnia in the beginning, I would maybe ask them to make some bigger changes in their life, like not having breakfast in bed, not having coffee in bed, because we do need them to start getting that bed to be associated with sleep only. That doesn't mean for the rest of their life they never get to have somebody make them breakfast in bed, right? But what we would want to make that change in the beginning. And then the other question was about
Oh, reading a book, like actually,
reading a
reading
book.
a book in bed before sleep.
Yeah.
Like, is that a good way to fall asleep?
It's a great way to get drowsy, but I would actually ask the person to maybe have a chair next to their bed that they could sit in and read and then get into bed just for sleeping, or read outside of the bedroom and then come and sit down. Because, one of the things that we do for stimulus control that we didn't talk about today is we don't lie in bed after waking up in the middle of the night and being awake for more than 30 minutes. You actually get out of the bed and leave the room, and you go and do something quiet and relaxing, like reading a book, before you return and get back into bed. And you wouldn't want to do any of that in bed, because again, that's making the bed a source of frustration and non-sleep time.
And I'll ask you we have a couple of slides at the end to follow up with, but someone asked, I feel like this is super important since our mission is to help people to learn team CBT. Someone said, do you treat CBTI as a standalone intervention, or do you go through the whole team model first, and specifically an assessment of resistance they're referring to? You want to do that one, Kevin?
Absolutely. Yeah. So I think that assessment of resistance needs to be used throughout the treatment, with CBTI as well as any other treatment. And so in the beginning, I'll be honest with the person about some of the changes that I'm going to be asking them to make that are going to be hard. And we're going to use some paradoxical agenda setting tools. So we'll take a look at all the good reasons to not do the things that I'm going to ask them to do, and to keep sticking with the status quo, and the disadvantages of changing, and then have them convince me why it would be really important for them to do some of the hard things I'm going to be asking them to anyway. And then it'll come up again later in the treatment, like especially with the reducing time in bed part. That's one that people really have a tough time with. And also, you know, you know, I'm in my 50s, so it's not hard for me to go to bed early on Friday night. But for younger people who want to be up until 2 or 3 o'clock in the morning with their friends, they have a real hard time with the I'm going to go to bed at the same time and get up at the same time every day part. And so rather than me talking them into living by my rules, I would bring to life with them all the good reasons to ignore what I say and do what they've been doing anyway, and have them convince me why it would still be important to change. Because um, I don't like to get into,
Yeah.
headbutting with people.
I'll say one more quick thing, Kevin, is just so if people are new to the Team CBT model or not. So we always say we do not throw methods at patients. We don't throw methods at diagnoses. So we are always treating patients within this framework of using testing or measurement, empathizing with our patients and connecting them, assessing and reducing resistance, and then using methods. And CBTI is kind of a toolbox of methods that we might use for people who struggle with insomnia. Also, Kevin and LJ only represented one small sliver of CBTI. So for people who are like, what do I do with people who are anxious about their sleep? Someone just sent that. Can you speak to sleep anxiety? That's a huge part as well. And there's, strategies to use for that, plus our typical kind of daily mood log and cognitive restructuring. So there's a lot that we didn't cover here today, both in terms of the whole framework of Team CBT, as well as even just specific methods for addressing insomnia. But that is because we had 1 hour rather than 3 days. But to that end, actually, will you move to the next slide and I'll share a little bit more with you guys. If you're interested in what we shared today and just generally interested in learning more about the TEAM-CBT model, how to use measurement and empathy, how to address resistance, how to use lots of methods with your patients, we totally encourage you to join our fast track course. This is a course people have been responding really well to, kind of a big investment of your time, but also a big change in your practice. It's a 6-month course that's a hybrid course where you'll both receive videos that you watch on your own, kind of a home study component, and then weekly practice groups where you're going to actually practice all the methods that you're learning in the weekly videos. And we have a kind of new cohort that's starting in January, on January 13th, and there's a discount that you can use for $50 off that's good until December 11th. And then for people who are more interested in just doing kind of the home study piece, like an overview of the TEAM-CBT model, there's the core skills of effective therapy, which is all video-based home study. And both of them offer continuing education credit. And I'll share one more quick thing, the next slide, which is that we actually have a workshop coming up on Friday, a full day workshop where David Burns and I are going to be teaching you in person or live streamed online on Friday, CBT tools and techniques for improving self-esteem and the sort of not good enough. So I know people have to leave. You got the CE survey in the chat box. If you'll just share the next one more slide. We just want to say thank you to Kevin and LJ for presenting and all of you for joining us today. We hope that you found it valuable and that we provided you with some good and helpful and practical tools to help your patients. And if you know of anyone who could benefit from our services, whether that's a friend or a family member or a client, you can check out feelinggoodinstitute.com to refer a patient or to get more training for yourselves. So thanks, and we hope to see you in our next webinar, which will be in February, the first Wednesday of the month in February. So happy holidays and happy New Year, and see you soon.